Welcome to Halteres Presents, a brand agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Thayer and Mickey Urdea.
Hello, and welcome to Halteres Presents. My name is Thayer.
And this is Mickey Urdea.
This is our second episode in a series on tuberculosis diagnostics.
And today we're going to be speaking with Peter Small, who we've known for quite a long while. And Peter has had a long experience with TB. He was both at UC San Francisco and at Stanford in different capacities. He was also at the Gates Foundation, headed up their global effort on TB for several years. And we're going to have a very interesting discussion because he has a unique perspective of TB, having done those things in the past and some of the things that he's doing now that he's going to tell us about.
And without further ado, here is our interview with Peter Small. Welcome, Peter. Thank you for joining us today. To start off, would you please tell us a bit about yourself?
So I've been blessed by a fairly eclectic career. I started as a doctor at UCSF at the dawn of the AIDS epidemic. I moved down the road and was a clinical investigator at Stanford during the dawn of molecular epidemiology, and then was recruited up to Seattle in 2002 to build and run the TB program for the Gates Foundation, which was really focused on product development. And the sort of a common theme throughout all of these has been tuberculosis, which has as its hallmark cough. And so I was thrilled about a year and a half ago to join a small startup that uses acoustic AI to make a Fitbit for cough.
Oh,
that's cool.
Wow.
So, Peter, we've all seen the positive effects that rapid global engagement to fight a disease can have. For example, smallpox, which is probably the most successful intervention ever to date. HIV, Ebola, and of course, more recently, COVID-19. While TB has been affecting humankind for more than 9,000 years, far longer than those other diseases, there's a consensus that not enough is being done globally to combat this devastating disease. What are some of the reasons for this historically inadequate response, and what role can improved diagnostics play?
Well, at its core, it's simple market failure. We got into a vicious cycle in which there was no market for TB products, and therefore there was no funding. With no funding, there was no promising science. Without promising science, there's no technology to invest and develop. And without something to develop, there was no clinical infrastructure. I mean, it was this horrible downward spiral for 30 years. And the tuberculosis product development virtually ceased. And, consequently, in those who were fighting TB, they were doing so with inadequate and antiquated tools. And perhaps not surprisingly, there was this learned helplessness amongst TB providers, which was to become accustomed to these inadequate tools. And, I sat in meetings in Geneva and heard people say, well, we've got the tools we need. We lack the will to deliver them. And I'm going, like, that tool you're talking about is 125 years old. It requires trained people, and it misses half the cases. It was crazy. And, I think the good news is that things have changed since then, and we've flipped to a much more virtuous cycle.
Mm-hmm. So what are some of the gaps that still remain that need to be addressed, do you think?
Well, look, we are far from where we need to be. Of the 10.6 million cases of tuberculosis that happened last year, only 6.4 million were actually diagnosed and reported. And of those, only it was estimated 2.5 million were actually diagnosed with modern molecular tests. So we have a long way to go still. And I think that in many ways, improving the diagnosis and treatment of TB is the lowest hanging fruit in tuberculosis right now.
Yeah. And the testing isn't necessarily where the people are, right? There aren't where the cases are. There are things happening there. How do you think that might change over time here? We see changes in the place of testing.
Yeah, I mean, it's a chicken and egg situation where if we had a good point of care test, we could be testing where the people are. If we had a good specimen transport system, we could make a lot more use of our centralized laboratories. And I think the only way to move forward when you are caught in this kind of a bind is to do what you can on all of those and let history play itself out.
Mm-hmm. And Peter, with that wonderful introduction, WHO has included ending the TB pandemic by 2030 as one of their sustainable diagnostic goals. And we're hearing of many exciting new advances, such as some of those you just mentioned, in tools to help fight tuberculosis disease that can also help us to attain this laudable goal by WHO. Some examples include face masks designed to non-invasively capture breath samples for testing, AI-driven tools and algorithms that are helping to broaden access to chest x-rays for detection of TB in more remote locations, next-generation sequencing intended to help monitor spread of resistance to TB drugs, new tests for detecting latent TB, and excitingly, improved treatment regimens that are much shorter to help increase access to treatment, and much more. What are some of the advances in TB diagnostics that most excite you, and how do you think they will help fight this pandemic?
Well, Rich, I think you nailed it. I mean, there's a lot of promising technology, and let me kind of come at it from the other end that Mickey just raised, and that is what is the end game. And to be clear, I'm not dogmatic about what that looks like. I'm super excited about improved centralized testing, where super high throughput brings in economies of scale and allows you to do much more sophisticated testing, whether it's a 6-gene RNA profile that predicts impending disease, or next-gen sequencing that not only tells you drug susceptibility instantaneously, but also tells you who is infecting who. I think the other approach, and the one that gets the most attention, is bringing the test to the people, and the issue there is it has to be good technology, simple, instrument-free, and we're seeing progress, as you mentioned. There's I'm excited about LAM. I think the Abbott test and the second generation Fujifilm and a whole slew of third generation LAM tests that may have higher sensitivity and performance outside of HIV infected patients. I think the progress that's being made in the ability to detect DNA, which is the ultimate biomarker and analyte, using lateral flow uninstrumented technology is super, super exciting. But I think that the issue, which is underappreciated with point of care tests, is that with a perfect test, it's very easy. You just simple self-test it and boom, you're off to the races. But there are no perfect tests. And then you get into the complexity of using imperfect tests. And an astute clinician runs through a complicated mental process of pretest probability, and then picking the right test and the post-test probability, ignoring it if it doesn't make any sense. I think maybe the single most exciting thing for me is the integration of testing technology with mobile phone driven analytics that automates and democratizes expert clinical care, so that you literally, you run a test, and if it was the wrong test to run, it doesn't give you the results. And so that there is a way that you can essentially bring that expert clinical decision making and integrate it with imperfect point of care tests. For me, that's a very straightforward and achievable goal.
Sort of a Bayesian approach, if you will. You're altering probability based on prevalence, maybe AMR, whatever the clinician requires.
Yeah, I mean, to date, I think what people have been forced to do is to take a test, set a positive and negative cutoff, do a study with an assigned pretest probability in which it gives you an appropriate answer. And there's a whole nother way of approaching this, which is that your action threshold is variable based on the prior probability. And so that if you're testing for HIV in a nunnery, it's almost impossible that you'll get a positive, whereas if you're doing it in other settings, it could be lowered considerably. And having all of these things adjusting dynamically so that you don't end up with the misuse of widely available technology, I think that's super exciting.
It absolutely is. Very attractive.
Peter, we're hearing a lot about non-invasive testing, so-called non-invasive. Could you elaborate a little bit further about that and some of the exciting advances that you're familiar with?
Well, yeah, I think it's part of a bigger movement about samples. And, TB has always been slave to the sputum. And now we're realizing that there are other things, stool for pediatric sampling, tongue swabs, using face masks. And, what I'm particularly excited about and have actually spent all my time on for the last 2 years is the use of ambient sound for triage and diagnosis. And we are surrounded by high fidelity microphones, and acoustic AI has gotten very, very powerful. And so, what Hyfe is the company that I'm involved in now is focused on is essentially, doing for cough what the thermometer did for fever. And that is to start by simply quantifying it. If you go to a doctor in this age of precision medicine, they will measure everything. But when you say, as you have a cough, which is one of the most common reasons people seek healthcare, they'll ask you, well, how bad is your cough? This is crazy. Imagine going to see a doctor and with a fever and having the doctor ask you, well, how high do you think your fever is? So, and it's a solved engineering challenge now. This freely available app, Cough Tracker, can actually recognize and timestamp and monitor cough in a way that preserves privacy. And I think that's going to have a profound influence on a lot of conditions.
Fascinating. So that can be one of those components of the pre-test probability you were just talking about, and integrate with improved laboratory testing.
Absolutely. And I was awake at 3 a.m. this morning, and someone happened to ping me with a slide that was presented at a WHO Diagnostics meeting where the folks from the Indian TB program were envisioning a world in which a cell phone app would be used to capture a patient's cough, and it would render its opinion, which would not be as good as a nucleic acid test for sure, but it would have some information as to its likely etiology. And then you answer 3 or 4 questions, and it would say, wow, this is somebody who desperately needs to be tested. And this front end of the funnel right now in TB is hugely problematic because we have a good test, but it's expensive and there aren't that many around. So how do we better triage technology? I think cough is a very promising approach. I've had a chronic cough for 30 years. I cough, I now know 40 to 80 times a day. That's just normal for me. And
Wow.
And yet about 3 weeks ago, I got an upper respiratory tract infection. So my cough is way up. I coughed 250 sometimes yesterday.
That's incredible. There's a little bit of a diversion here, but I find this whole notion of monitoring things on an ongoing, consistent basis versus maybe once a week, once a month, once a quarter, the amount of additional information is way beyond simply the number of times. It's the information content. And it's astounding how that's expanding so rapidly in so many areas, including the cough that you were just talking about.
No, absolutely. I think that this paradigm that a person who has tuberculosis will get ill to the point where they will take time away from work and family and other responsibilities to seek care in a clinic, which is invariably, crowded and understaffed and inconvenient, and then get a diagnosis based on a, 3-minute interview and a sample, that's just old school. I mean, the future is much more about continual diagnostics, in which, we are somehow harvesting the appropriate parts of the data stream that we all leave behind in our lives, and using that to recognize and alert patients when their health is starting to deteriorate. And we're seeing this in so many ways in rich countries. And I think the big question is, as the data trail of people in lower and middle income countries start to grow, how can we adapt that paradigm for the people who most need it?
Right. Yeah. See, the wastewater surveillance will move closer to home. It'll become the smart toilet. And then we're off to the races.
Yeah.
Imagine if you could use cough to somehow monitor that continuum or that transition from TB infection to active disease, rather than trying to come up with some super new, molecular test. It's quite fascinating.
Yeah.
Well, and I would just add that anything that is said today about cough is what I was trained as a clinician to refer to as a clinical pearl, but that as a scientist I know is code for bullshit. And it's like when someone says, "Oh, well, only this percentage of TB patients cough," ask them how they know, because patients themselves often don't know when they cough. So I think simply defining the basic epidemiology of cough in TB patients. And there's a fascinating paper that was done by a group at UCSF where they used our technology to monitor TB suspects, about 500 people who were suspected of having tuberculosis in Africa. And they showed that at baseline, those who actually had TB had 3 times as much cough. And super interesting was, and not surprising, is that with empiric therapy, those who actually had TB, their cough dropped like a rock in 4 days, whereas those who didn't have TB, it wasn't changed. Mm-hmm. So, once we start thinking about continuous data and how it informs patient diagnosis and management, I mean, I'll get shot for saying this, but since I'm rarely around TB people, I'll just go ahead and say it. You could even envision settings in which you would use empiric therapy and the 5-day response as a way of diagnosing tuberculosis. And and I say that with fear and trepidation, because empiric treatment of TB is fraught with evil. But if done smartly with the appropriate monitoring, I'm not convinced it's not worth exploring.
Yeah. So, Peter, we know there's an increased interest in creating or providing a more patient-centric approach to TB management. I know you're quite interested in this. Can you tell us a bit about that approach and how it'll benefit people that are infected with MTB, providers, healthcare systems, whoever else the appropriate stakeholders are?
Yeah, I mean, let me be very clear up front that I think that DOTS was one of the world's greatest public health innovations, and I credit it with saving millions of lives. But also, let's be clear, it was probably the most provider-centric and frankly paternalistic approach to healthcare delivery ever invented. And and that was the context of TB when I entered the field, some 89 years ago, and my world at that time were like ministers who were trying to make decisions about resource allocation, and providers who were demanding that patients have their medication observed, and epidemiologists who studied cohorts, and somehow what got lost in this approach was the patient's journey, and for me a big transition was the 2 years I spent living and working in India. in which I drove thousands of kilometers in very remote areas, trying to understand what it was like to be poor and sick, and where people go for help, and what the barriers that they had to overcome. And in the end, I think it's really kind of that approach has been formalized in that we're still seeing annual cohorts and WHO reports and whatnot, but in the countries themselves, programs are increasingly relying upon this so-called pathway to care. If you start with 1,000 people who should be tested for TB, how many actually get tested? How many actually who are positive get treated? And what are the barriers along the way that you have to overcome? I think it's been a fantastic transformation in terms of putting patients first and understanding that not just the technology that's needed, but that the health systems changes that were needed, which ultimately come down to finding a way to incentivize everybody in the system to do the right thing.
Absolutely. We've been doing a fair amount of work recently on workflows in TB clinics, and just recognizing the inefficiencies. And a lot of it almost certainly is because of that lack of incentive systems. And it can just be so much better. Getting the patient in, tested, and treated in the same day is a laudable goal, but very difficult to do without some changes in incentive systems.
Well, beyond difficult, it actually becomes impossible if the compensation for a provider for doing that is a third of what they would get if they drag it out over a week and bring in a bunch of unnecessary testing and treatment.
Right. Yes. Perverse incentive systems.
Absolutely.
Peter, I'm reminded of an ICAT meeting I went to a couple of years ago in Eswatini on HIV. And the whole discussion was around potentially dropping the cutoff for viral load and the use of CD4, and perhaps why it might be smart to reintroduce CD4 and sorts of things. And one part of the presentation was actual individuals infected with HIV, people living with HIV, coming up and presenting to a very large audience, pleading, involve us in these discussions and decisions. It took our community a better part of a decade to understand what a viral load even was, and why we were monitoring, and what the values were, and what was important and what wasn't, and the impact on so-called drug holidays, et cetera. Now here we are talking about changing these cutoffs or reintroducing CD4, et cetera. Is there a corollary that perhaps you're referring to here now in the world of TB and the importance of becoming more patient-centric?
Oh yeah, absolutely, and I credit the HIV community with having brought about this change in no small part. I mean, it's when I started doing tuberculosis, you sort of felt that patients were so unempowered that if they got to a clinic and waited all day in line and the doors closed just as they got to the front of the line and they were told to come back the next day, they just went home and came back the next day. And that was in striking contrast to an active and empowered HIV community, who were laying in front of the buses in San Francisco because they weren't getting the most recent antiretrovirals in a public clinic. And I credit that community, the groups like TAG, who were able to bring a mindset and ultimately brought to, I think, far greater prominence empowered patients and ensuring that their voices were heard.
You remind me of something that happened to me when I was at Chiron, when we were developing and introducing the first viral load assays, and the ACT UP people were very, very encouraging. Used to come to our office to talk all the time. I'll never forget that the head of the group told me, look, if you need us to go to the FDA and chain ourselves to the commissioner's desk until he gives you approval, let us know. Said, no, I don't think we're quite ready for that. But man, having them involved was really helpful.
Well, and the flip side is I remember in in some of my clinics in San Francisco as some of the antivirals were just coming out. It was quite threatening as a physician who had always known more than the patients about their antihypertensives to have people come in and say, doc, there's something new and you should be doing it. And I, honestly, it was an uncomfortable transition for me. And I think, it's something that many providers around the world are just frankly not ready to or willing to engage with, empowered and educated patients who are demanding what they should get.
Peter, it's been a great discussion. We have heard that the fight against tuberculosis has been set back about 10 years or even longer as a result of the COVID-19 pandemic. However, on the positive side, one cannot help but hope that great strides made globally to improve access to and availability of next-generation technologies to fight the pandemic will ultimately benefit TB and other diseases. These advancements have been made possible through generous new funding sources such as access to COVID-19 tools, or the ACT-A Accelerator launched in 2020, and the Rapid Acceleration of Diagnostics, or RADx initiative launched by NIH in the US. More recently, as a result of the hard work, in addition to the result of the hard work of thousands of groups around the world. Can you share some examples of the more promising accomplishments in diagnostics, in your opinion, and how these accomplishments might better help prepare us for the next epidemic?
Yeah, let me flag 3 accomplishments and talk about how I think they might converge. And there's no question that the first is COVID, and okay, it's been an unmitigated disaster, and it's said that TB deaths have increased from 1.1 to 1.6 million as a result of this, including basically 215,000 kids who are dying of preventable diseases now. So don't get me wrong, I'm not saying that COVID is an accomplishment, but I will say that what COVID accomplished was that it accelerated innovation, and that people are more open to radical change now in health systems than at any point that I'm aware of. The second, I think, are mobile phones, and we've heard since they were introduced about telehealth and remote care and all these great things were going to happen, but they're actually starting to happen. The digitization of healthcare and the way in which things like, for example, cough can be tracked with mobile phones is a serious accomplishment. And the third is big data. And if you've not read Shoshana Zuboff's book, Surveillance Capitalism, it's a fantastic read, and it outlines a pretty grim future. And yet, I think that the big data has been a huge accomplishment and has potential for shifting from what is now probably surveillance for wealth to surveillance for health. And the ability to use some of the technology that's currently being used to sell me, ski gloves to improve public health is another accomplishment that we're starting to see some concrete progress in. And I think it all converges in the future that would help in a pandemic in giving us some real-time situational awareness based on automated analysis of passively collected data that would permit hyper-local responses in a time frame that can have a real impact. And I, for one, look forward to the day when I get pinged that my cough has increased significantly, that flu's on the rise in my neighborhood, and that a home test is being delivered to me that afternoon.
Right. And you can imagine if the quantitative cough pans out, monitoring areas and suddenly seeing there's so much more cough associated with TB here. Or on the other side, much less as a result of the interventions that are working better.
Disappeared.
Yeah. Disappear. There are other ways to do this, of course, wastewater management as well, which I've not seen TB in that regard. Have you? I've just not seen that yet. Yeah.
Yeah,
So thank you
we've
for
heard
that.
about polio and monkeypox and others, but not in the TB community yet.
Yeah, so many other things. Absolutely.
No, I think that the potential utility of aggregating data, which individuals are collecting for their own benefit in a way that is de-identified and privacy preserving, is phenomenal. And in fact, we tried this when we had a very early version of the app in a community in Spain, and we enrolled 900 people in a study and attempted to monitor their cough and see if community level cough awareness would precede other indicators of respiratory pathogens. And the short answer was it didn't work, as is true for most of the experiments I've done in my life. Yeah. But it was for reasons which are addressable, and so I'm super excited about what it would add to things like the influenza-like illness monitoring that is done in emergency rooms, to have truly passive syndromic surveillance. I think this is super interesting.
It really is. We've talked before about a new world in which all of these forms of information are integrated and used by various stakeholders. So you can go so far as to say, not only do I know there's TB here, but now I need to start diverting drugs toward this. I need to increase the supply chain for the tests. You can do it all in real time. You can imagine this all being very well integrated, and it really builds off of that surveillance culture, but in a much more positive way than creating advertisements. I also love that book, by the way. It's fantastic.
Yeah, and we about a year ago, I changed my profession on LinkedIn to acoustic epidemiology, and people say, well, what is that? And I was like, I don't know, I just made it up. It's but we're starting to understand that actually sound is a powerful signal for understanding the distribution and cause of and management of disease. And it doesn't have to be limited to humans. For example, swine flu and look, any animal with lungs coughs. And I have spent days on YouTube listening to horses, cows, dogs, cats, rats, mice. They all cough, and so I think that there are ways that we can use sound to track not just human but also animal diseases in a way that fits into this whole field of One Health, which I also think is incredibly promising.
So do bats cough?
They have lungs. They do.
Yeah.
They must.
So let's start monitoring bat caves and see where they're sick, and maybe pick up that next coronavirus before it spills over.
I love it.
So, Peter, very interestingly, you mentioned the accelerated pace of innovation around COVID diagnostics, et cetera, and the apparent more openness for people to accept that rapid innovation. Do you think that will stay with us? Do you think as the new tests and new technologies are being developed and coming out for TB or other disease states, that acceptance is going to stay with us?
Well, they're not going to be able to take away from us what has worked well. But I think they could reset the parameters for innovation back to a much more conservative space. And I think at some level it's understandable, because health is not a sphere in which you want to first, have some creative destruction and break it first. On the other hand, that's often, just a smokescreen for entrenched interest groups. And so insofar as it will be hard to dial it all the way back to the kind of sclerotic systems that we've had in the past, I do suspect that innovation will slow down, but I don't think they can take away things that we have shown to be unequivocally good.
I wanted to ask you one more question, though, Peter. The first time I recall meeting you at the Gates Foundation, and we were talking about what it was like to work there, and I recall that you said something along the lines of, the first time you met Bill Gates, he asked you the two most interesting questions you'd ever gotten concerning TB. Now, am I remembering that correctly or not? I don't know.
Well, yeah, the first time I met Bill was at a big social event, and he locked into a conversation that went so deep, so fast about technical issues in tuberculosis that, frankly, most people who were spending their life in the field could not have had. That it was sort of mind-blowing to me, and I think characterized much of what was so great about working at the Gates Foundation was, the willingness and actually the insistence on going deep on the science as we contemplated, where investments would have the most impact.
Very interesting. Yeah.
Okay, Peter, thank you very much for your time today. It's been a very interesting conversation.
Thanks so much for having me.
Absolutely.
Thank you.
Bye-bye.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.